All right, so I'll present a brief instructive case here. We have a 31-year-old right-handed woman with the chief complaint of dizziness and nausea. She tolerated that for about 6 weeks, and it was vertigo rather than pre-syncope, this sort of a quote-unquote dizziness. And during the 7th week, she experienced vomiting and facial numbness and had difficulty walking. So that led her to present to a local emergency department. So in her past medical history, not too much significant there, although her mother does have scleroderma, so an autoimmune disease in the family. No medications, no allergies for her, no significant history of any substance abuse. On exam, she had downbeating nystagmus, right facial numbness in the V3 region, mild left hemiparesis with hyperreflexia, some ataxia on the right, and gait ataxia just generally. So here is her brain MRI, and there's just a few representative slices here. So we definitely see brainstem and middle cerebellar peduncle lesions, some lesions around the fourth ventricle there. There are numerous periventricular lesions as well, some subcortical lesions. And if you can see on our bottom right panel there in the mid-sagittal plane, you can see there's a C2 spinal cord lesion as well. And further up the brainstem, there's also a lot of signal abnormality along the dorsal brainstem near the fourth ventricle. Several of these lesions scattered throughout the brain, enhanced with contrast. You can see sort of what looks like an open ring enhancement pattern on some of these. And for the laboratory workup, she had a spinal fluid done, which showed a lymphocytic pleocytosis. There were oligoclonal bands, and a variety of antibody tests were unremarkable. And so this looked like an open and shut case of multiple sclerosis, pretty kind of garden variety here. But further testing did show a positive MOG antibody cell-based assay. So this actually changes the management for this patient. And just to wrap up quickly here, so for the take-home points, MOG is myelin oligodendrocyte glycoprotein antibody disease, which has been carved out of NMO spectrum disorders, which itself was carved out of MS over the last 15 years or so. And MOG regulates oligodendrocyte microtubule stability, and also the antibodies to it can activate complement. And those of you that are familiar with care for NMO these days know that one of the new treatments for it actually blocks complement. So that's a similar mechanism. So the differential diagnosis, of course, includes MS and NMOSD, but usually it's the other way around. Usually you're thinking about something more common like MS, and MOG is in that differential diagnosis. And so some common presentations include optic neuritis or transverse myelitis, but also brainstem and ADEM-like pictures can be fairly common with this as well. And the key take-home point is that the disease-modifying treatment options differ from MS, with the exception of some overlap of the anti-CD20 B-cell agents. Patients with MOG often are treated with mycophenolate or azathioprine as well. Another key point here is that generally MOG sometimes travels with NMO in your differential. They generally don't overlap as a syndrome, but if you're thinking about one of these, then you would try not to give certain MS medications like interferons or perhaps S1P inhibitors or integrin inhibitors, because they can actually make it worse. And with that, I will wrap up and turn it over for our main presentation today.
Thank you, Dorlan. That was a model of brevity and clarity.
Thanks.
All right, can you see my slides?
Not at the moment.
All right, let's try that again. How's that?
Perfect.
All right. All right, so I'm thrilled that today's speaker is John Krakauer. Whenever John speaks here, I have to check up to see what he's done lately. And so you pop John into Google, and Google says, "Did you mean John Krakauer?" Sorry, John. But in another year or two, when you put in John Krakauer, it'll say, "Did you mean John Krakauer?" So I always like to introduce John as not the author. John Krakauer, the author, wrote Into Thin Air, which, and if any of you haven't read it, is an amazing book, and several other books as well. But we're more than fortunate to have John Krakauer, and I'm fortunate to have him as a friend. So John went to the University of Cambridge, which is surprisingly different than Harvard. It's a place in England that's also not Oxford. And here's a picture of it here. He got his MD at Columbia University, and I'm sure while he was there was the inspiration for this building. John, is that a true story?
I was actually, I was invited to be the inaugural debater in that building, actually.
Yeah, well, it makes perfect sense.
For it.
For anyone
see that thing at the bottom, there's an auditorium at the bottom that's really very cool, and they made me be the debater to open it, so it was very nice.
No doubt. So John, just to be ornery, decided to do, he was going into neurology at Columbia, but decided to do an internship at Johns Hopkins just to see if he could survive. Then went on and did his neurology residency and stroke fellowship at Columbia. He began his research career with Riza Shadmir and Pietro Mazzoni on motor control while at Columbia. And then I wrote down here, I said, although it would be incorrect to say John was trained by anybody. He is now the John Malone Professor of Neurology, Neuroscience, and Rehab at Johns Hopkins, and director of the Center for the Study of Motor Learning and Brain Repair. Has that replaced BLAM? What happened to BLAM, John?
No, it's BLAM. That's just a misnomer. That's
They didn't get the memo.
Yeah.
But John is so much more. He's a comedian, he's a gourmand, and he's an intellect. Various moments from our life. The reason this is me and John is this is like the only time I've ever cooked for somebody. I made John a bagel with butter on it. Do you remember that, John?
I do, fondly.
It was, I think, a cinnamon raisin bagel, if I'm not incorrect. So we're thrilled to have John, as always, and he's going to talk to us today about brain plasticity and stroke rehabilitation. So I'll throw it to you, John.
Thank you, Rich. That was lovely, I think. And I'll share screen. Is that okay?
Yep.
Can you see that?
Yep.
Mm-hmm. So I should do play, right? Is that okay still?
Beautiful.
All right. Well, thank you, Rich. It's lovely. I know that you have a compressed hour, so I'll get on with things. I changed my title a little bit just to try and sort of frame the problem a little differently. So I'm just going to talk about hemiparesis, which is probably the garden variety deficit that one sees in neurology. But I'm going to try and show that it's actually a very complex phenomenon and needs to be dissected down into its components, rather like Parkinson's disease does, or even schizophrenia for that matter. So let me move forward. This is our website, BLAM, and this is a book I wrote about 3 years ago, which covers a lot of this material. I wrote it with Tom Carmichael at UCLA. Just a plug, shameless, I know. So I'm going to talk about, go back almost over a century, and a debate that went on between neurologists and physiologists, which was that stroke in humans led to these two sets of symptoms that actually Hewlins-Jackson talked about in the late 19th century, which were the negative symptoms from loss of control and positive symptoms from the emergence of the lower center. So these have been around for a long time. To put that in our language, you have loss of dexterity and strength in stroke, and then you have intrusive postural abnormalities, synergies after stroke, and spasticity. And then FMR Walsh, who was a neurologist at Queen Square in London, talked about this dual nature of hemiplegia, this combination of loss of voluntary movement and the intrusion of positive phenomena, spasticity and synergies. Now, it may be interesting to you to know that, back then, and this is relevant to what I'm going to show you later, there was quite a lot of crosstalk between the physiologists, for example, Sherrington and Leighton, and the work they were doing in non-human primate models, and the neurologists. And one of the interesting debates, which sort of got forgotten about and has had consequences for us up to this day, is that the monkey models, the classic ones by Sarah Tower in 1940, and then the Lawrence and Kuiper's papers in 1968, was that they would make a pyramidal lesion in the monkey, right? And the monkey would lose dexterity and lose strength, but it wouldn't develop the positive symptoms. So on a historical note, the term extrapyramidal, which has become almost a byword for movement disorders, actually came from the debates as to why pyramidal tract lesions in the monkey model of stroke did not cause both the positive and negative symptoms. And so the term extrapyramidal was coined to say they must be somewhere other than in the pyramids. So the term extrapyramidal comes from stroke. And it's important because stroke should be viewed as a movement disorder through its positive symptoms and a more classical deficit disorder through its negative ones. And this double nature, this dual nature of hemiplegia is haunting us to this day. And it's underappreciated, right? As Santayana said, those who know no history are doomed to repeat it. So let's talk about these positive symptoms. So you all have seen the, you see a patient in the corridor, you can see that they've got this upper limb posture even when they're not trying to use the limb. And then of course they have all sorts of difficulties when they try and use the limb. So here's this what you see. So you have this flexor posture, depressed and protracted shoulder, the arms adducted internally rotate, you've got flexion at the elbow, pronation, and you have this flexion at the wrist, okay? But what's important to realize is this is an abnormality at rest, okay? It's like spasticity, which is a rest-elicited abnormality. Indeed, just as an aside, there's no evidence up until this day that one should do anything about spasticity for the upper limb because it doesn't seem to change motor control. But nevertheless, we still have a large Botox industry when it comes to the upper limb for stroke. So this is a very classic paper. This is from 1951 from Twitchell. This is a time when papers were long and had more patients than authors. And he was interested in looking at the natural history of recovery in humans after stroke. And an interesting historical aside again is Twitchell actually spent time with Denny Brown up at Harvard, who was doing very seminal work in the monkey and actually wrote a book in 1948, which is very dense, which I read and actually led to some work that I'll talk about in a minute. But again, if you delve into some of these old papers, you can find all sorts of things. And this Twitchell Denny Brown dyad was a repetition of the fMRI Walsh Sherrington dyads that were happening in the beginning of the 20th century. And I think that's something else that should happen much more, is there should be much more crosstalk between physiologists and neurologists. Unfortunately, we're entering the era of mouse models, and monkey models are in danger, but I will make the case today that without a monkey model, we'll never treat stroke. So here's the Tritula recovery sequence. So basically you go from plegia to beginning to develop a flexor synergy around the shoulder, then it's joined at the elbow, then you get some flexions. And importantly, this is a recovery sequence from movements that are elicited during voluntary movement. In other words, this is not the posture at rest. This is what happens when somebody tries to move. They get these obligate co-contractions or movements across more than one joint, even trying to isolate one. And that's why it's called a synergy. And then you might progress into a joint by an extensor synergy. And then if you're lucky, you can begin to make out of synergy movements and do finger individuation. And this is the recovery sequence basically of the positive symptoms, the synergies. And this is what the Fugl-Meyer was actually designed for, a scale from the 1970s, which was deliberately Fugl-Meyer's decision to try and find numbers to quantify Twitchell and Brunstrom's sequence for the positive symptoms called synergies. Negative symptoms is loss of motor control. So you can actually now try and isolate and study the loss of strength and or loss of dexterity, more importantly, loss of motor control. And to do that, you have to have setups where you can minimize the contributions of the positive symptoms, for example, and the weakness. So here's a system that we've used a lot. You basically have support of the arm on an air sled, so it removes a lot of the effects of gravity. You have loss of, you can remove friction. And then it's an assay. This is not a task. This is a motor control assay. It basically shows that the human brain can make the arm make straight, accurate movements to targets arrayed in a circle if motor control is normal. Okay, you should see this as the arm version of finger dexterity. Okay, but instead of around the fingers, it's around the elbow and shoulder. Okay. Now, what happens after stroke is that you lose that dexterity of the arm, just like you use dexterity of the fingers, and you end up having inaccurate, curved, highly variable movements like you see there on the right. Okay. And the important thing about this assay is you can't compensate. If you can't cheat to make the movements on the left. If your motor control is abnormal, there's no other way to make the movement to try and fake it. Okay, so this is quite a pure assay of your arm dexterity. And if you quantify that, which we did, and this is a study going back several years now, just take my word for it that you can quantify the quality of those trajectories, and you can come up with a multidimensional state space with a distance measure in it that relates how far from the left you are on the right. So you can actually come up with a scalar metric of your dexterity distance from normal, and that's what's plotted on the y-axis, and basically you can see that that levels off after stroke within about 5 weeks. So there seems to be a window, at least for spontaneous recovery, along with conventional rehab, which doesn't really target dexterity in my view. You have this window, and measured with this assay, and you can see the dotted line down there. That's how age-matched controls behave. So there's a huge amount of space between the plateau of the patients and what you could do. Okay. Now, what's interesting is if you start looking at patients, you can dissociate the movement disorder from the motor control disorder. In other words, the mechanics, the underlying dynamics of recovery of these components dissociates. That's important, right? Because you have to decide if you're going to do a trial, well, which component are you targeting? This is very similar to negative and positive symptoms in schizophrenia. The drugs don't work equally well on the negative and positive symptoms. Same thing with Parkinson's disease. Some interventions do well for the tremor and the bradykinesia, but they don't work so well on the postural instability or the cognitive deficit. So it's extremely important in all these conditions to be a splitter rather than a lumper, rather than just trying to sort of have one treatment that treats the whole thing, okay, because it won't work. Now, if you start dissecting, so this is a way of dissecting using a similar system to the table I showed you, the postural forces at rest, you can actually just move somebody passively across the workspace and then just record what kind of forces they are exerting on the manipulandum, even when they're trying to relax. So if any of you guys did it, you know, you'd move across the table, you'd just be passively moved by the robot, and then you would just relax. You would be exerting no forces. But that's not true in patients. So across the workspace, they develop these force fields. This is work by Alka Joseph, a postdoc in the lab. And basically, quickly, I mean, I don't have long, but these are heat maps showing the force fields of postural force generated by a patient. And you can see up in the left-hand quadrant that unlike their unaffected side on blue on the right, they have this vector field of forces in flexion directed towards their body, even when they're trying to relax at rest. Okay. And what's interesting is if you give them arm support, in other words, you give them support at the shoulder orthogonal to the directions they're moving on the workspace, those forces reduce. This is very similar to Jules Jawol's work on synergies during movement, that interestingly, reducing the weight bearing requirement of the arm at right angles to the control directions interestingly seems to reduce the expression of this postural abnormality. Okay, and we can talk about that a little bit later. But in other words, you can begin to sort of dissect the components of hemiparesis, and here's one of them, these abnormalities at rest that you're seeing here, which can be modulated by weight support. Now, interestingly, what you can do is you can now see what the relationship is between these abnormal postural forces at rest versus actual movements. In other words, this is very analogous to what's been done with spasticity. So you can elicit spasticity at rest, and then with a torque motor, you can try and elicit spasticity during movement and it goes away. So in other words, it's an assumption that have been made for a long time, including by Twitchell, that any abnormality that you see at rest must be a relevant abnormality during voluntary movement. That's not true. You know, another example of that is the rest tremor in Parkinson's disease. It goes away in the most part during movement. Okay, so in other words, to just assume, like Twitchell and many people do, that if you treat the resting abnormalities, it's going to spill over to the voluntary movement, is an assumption that is often wrong. It's been wrong for spasticity, and it's wrong here too. And this is just showing, in the interest of time, I'll just tell you that you've got the resting abnormalities on one axis and movement on the other, and they don't correlate. Okay, so again, interestingly, you can see these abnormalities that you can dissect, and they're not all related to each other. And this is just showing Jules DeWolle's work, where he just shows that the more weight support you give the paretic arm at the shoulder, the more workspace volume area you can cover with extension at the elbow. So you're seeing increasing areas on the left that can be covered by the elbow if you use weight support in the arm. This is the synergy voluntary equivalent of the resting experiment that I showed you that we did. All right. Now, why am I telling you all this? It's because unless you do this level of granularity of dissection of the abnormality, you're not going to successfully treat this disorder, neither the movement disorder or the deficit disorder. And coming up with some lumped clinical scale and putting it into a rehab trial that, like, has happened over and over again, and all the trials, almost without exception, have been negative. And one reason for that is that there's a binary star of a relationship between the quality of your dissection of the abnormality and the ingenuity of your intervention. Okay, you need to know mechanistically what you're going after. All right. Now, interestingly, as I said to you before, in the monkey models going back over a century, they couldn't get these abnormalities. So as I told you before, I sort of was puzzled about this, wrote about it, read the Denny Brown 1948 book about this, and said we need to do something about this. So we suggested to the NIH that we should actually build a new monkey model of stroke and try and see if we can recreate these synergies. Okay, so that's what we're currently doing with a very prominent primate physiologist in England called Stuart Baker. And I'm just going to show you very quickly some preliminary results, where basically this is a cross-sectional MRI of the macaque. This is the central sulcus you can see here, and you can induce a cortical stroke. Importantly, it's a cortical stroke, right? It's not a pyramidal lesion. Pyramidal lesions are trying to isolate a particular, the monosynaptic corticospinal tract, okay? And the Denny Brown book, if you read it, and I don't recommend it, it's somewhat turgid, there are clues that with cortical lesions, there may have been a whiff of synergies in the monkeys, okay? And so I won't go through the data now, but it's interesting that if you look at the EMG of the monkeys, you can begin to see the turning on of flexor synergies with these cortical lesions. But interestingly, you don't see them in the kinematics. And one of the reasons why that might be is that the red nucleus in the monkey seems to be far more of a player when it comes to projections down to the ventral horn. So at the moment, we suspect that unlike in humans where the red nucleus has become vestigial, the monkeys can perhaps combat this unwanted turning on of these synergies with cortical lesions by having a red nuclear output. But watch this space. I'm just telling you that my suspicion is that we're going to need a monkey model, just like Parkinson's disease needed one with Malin DeLong for DBS in order to treat chronic stroke, especially if we want to have an effect on the positive symptoms. Here's another example that I'm uncoupling. These are controls making movements on that table. Here are chronic stroke patients making those movements, and those are their Fugl-Meyer scores at the top there. And then here are acute patients with similar Fugl-Meyer scores trying to make them. And what's very nice here is you can see that for matched Fugl-Meyer scores, in fact, superior Fugl-Meyer scores in the acute patients in cases, their kinematics is worse. Okay, and this is it tabulated over here. So here's another example of where one scale is dissociating and uncoupling from the dexterity. Okay, so over and over again, depending on what you look at, you see different components of the paretic phenotype going off on their own. Oh, and here's a result from the monkey, but I won't go through it now. I just had the slides out of order, but here this is just beginning to show that you can actually see flickers of synergies in the monkey if you look at EMG, but it's not so apparent in the kinematics. So we're in this kind of state when it comes to the study of stroke with animal models and humans. These are the components on the left: motor control, strength, synergy, and then compensatory movements. And then on the top, I've got the mouse, the monkey, and the human, and I'm basically showing the little ruler means, do we have metrics for these? And then the hammer and the wrench are telling us whether we have treatments. Do they respond to the treatments? Okay. And as you can see, for synergies, it was gray, not applicable, until I hope the model that we're building now for the monkey. All right, and then when it comes to humans, it's an open question whether we can actually treat beyond compensation motor control and synergy abnormalities, the primary positive and negative symptoms. Now I'm going to show a study quickly because Rich was very much involved in this study, just showing this critical window notion. Just like you saw, I said after 5 weeks, dexterity stops improving in human stroke patients. It's even worse in the mouse. It's over within a week or two. This is work that Steve Zeiler, Rich O'Brien, and I and others did. Basically, there's a lot of argument about whether you can look at reaching movements in the mouse. Is there homology in the evolutionary sense? And the argument answers yes. Here is one of Steve and Rich's mice reaching. This is when they were still learning how to do it without trying to involve their tongue. You can basically then induce a stroke over the cortical surface. There's that stroke, that bruise. You can then train the animals on that reaching task to about 55% efficacy. It's quite difficult for them. It's a cortically dependent behavior. And then you can give them a stroke, and of course they get worse. And then you can wait about a week and you can try and get them back to normal, and you can't. So this is 3 weeks of quite intense training on the same task, more than actually humans get, but you never get back. However, if you start early, you can go back to normal. Okay, so this is a very nice demonstration of the idea, and this has been recapitulated in monkey models as well, is the earlier you start training, the more likely you're going to be able to truly reverse the deficit. Okay. And then, you know, these were a series of studies that we did with Rich. This was the last one where there was this sort of idea, well, let's delay like we did before, but maybe paradoxically, if we give the animal a second stroke, we can reopen the window again, and it will initially be worse, and that's exactly what happened. Okay, so in other words, you treated a stroke with a stroke by not delaying the second time so that you could actually get on with fixing the original stroke plus the new one. Very entertaining, slightly counterintuitive result, but I think it makes the case that you can actually reopen critical periods with stroke. Obviously, this is not going to become a treatment option. And this is a study which I won't go into detail, it's in the book, but this is showing a very similar result in the monkey, a study out of Japan. Okay, they didn't do a second stroke, but they definitely showed that a lot of training early gives you restitution rather than just compensation. So a trained monkey goes into the pink, which is restitution, an untrained monkey goes into the yellow, which is compensation. Okay. And you know, all this work in the human, the monkey, and the mouse led me to come up with sort of a heuristic equation, which I think helps, in fact, summarize all the data. I challenge anyone to say it doesn't at the moment, which is that restitution, actual recovery, is a function of the dose of behavior multiplied by the amount of residual architecture that you have latent that is already dedicated to controlling that effector, by the amount of plasticity, in other words, how much you respond to training. So in other words, this equation is saying, and I'm saying, there's no such thing as reorganization. Everyone talks about reorganization, and I'm happy to talk about it. It's a myth. What you get, in fact, is behaviorally and plasticity enhancement of pre-existing dedicated representations. Arm areas don't turn into leg areas, face areas don't turn into hand areas. None of that happens, okay? What you do is you upregulate latent architecture that was already dedicated to that function. So the challenge remains to reverse the positive and negative symptoms, not just compensate. Okay, that's what we need to do. Now, from the rodent literature, we know that 3 things can actually help restitution. One is exercise, B, in other words, cardiovascular challenge. The other one is what we've been talking about, just training on the task itself, C. And then A, it's great if you're in an enriched environment. You have 75 years showing that being with your friends, exploring new spaces, toys and ramps help a lot. Okay, so how do we in a human combine A, B, and C? I will skip that. And so we wanted to come up with something that was playful, just like the enriched environments in rodents. And the first thing we need to do is we need to make people play in a statistical cloud of everyday life. In other words, we wanted it to be non-task based. And this study by Daniel Walker and his colleagues showed that most of us in everyday life, if you do motion tracking, for most of the activities of the upper limbs, we live in these donut ellipses, right? These clouds of everyday life. So this was an inspiration to us that we were going to make people make movements at high intensity and high dose in this statistical cloud of the movements of everyday life without any particular focus on a particular task. Right? So what would an enriched environment patients look like? How should we promote playful non-task-based exploratory behavior? Well, we thought that the clue came from the world of Disney and Pixar and animation, where people have been enthralled by characters because of their movement. The illusion of life, in fact, refers to movement being so joyous that you assume that the characters are alive. Okay, so it was what we thought was, it was a short hop, skip, and a jump of Pinocchio to saying, don't just watch, be the character. All right, and that led to a trial where we were going to try and recapitulate the rodent and monkey experiments of high intensity and high dose plus enrichment, but do it in humans. Okay, and the idea was that you would isolate dexterity in 3D by getting weight support by an exoskeletal robot, no assistance along the line of movement, and you would become a character immersed in an environment. Okay, and it would be that dolphin swimming around that would make you babble like a child in a non-task-based way in that statistical cloud of everyday life. Okay, this is the details of the trial. I'm going to just, so there were 3 arms basically. One was allowing therapists to time match what we did with the dolphin. That was a lot of therapy, just so you know. It was an hour in the morning, an hour in the afternoon of time on task upper limb therapy. That was the same with the dolphin, 5 days a week for 3 weeks. So basically imagine having 2 squash lessons every day, 5 days a week for 3 weeks. That's how intense it was. And then there was we were lucky that we had a 3-week regular therapy matched control group from Gert Quackel. This is what it looks like. I'll quickly show you what it feels like for the patient to be doing this. So you're the dolphin, you have to get the fish. There's an AI algorithm. They get smarter and smarter as you go. This animation is so proprietary that in fact, Ed Catmull, the president of Pixar, visited us to see it and invited us out. And he agreed that you need to have something extremely beautiful and immersive in order to have patients do the kind of high intensity and high dose required. As you go, it gets more difficult and you end up combating sharks. But I hope you get the idea. This is very sort of mesmerizing, almost amniotic sort of experience. The lights go down, the music goes up, the patients don't even see their arm. Okay. You get the idea. And here's the results, very interesting. So the paper was just published in NNR just this week or last week, can't remember, last week. And what was interesting is that on the ARAT, which can be considered a prehension task, closest actually at the current time to what monkeys do when they reach out, or mice do when they reach out for pellets, the treatment of both high intensity groups was twice as good as any regular therapy on the ARAT. So all those blue lines are different sets of patients getting regular therapy compared to our acute therapy combined here, because we didn't see a difference between giving 2 hours of extra time with the therapist and doing the dolphin. Okay, and I'll talk about that in a minute. But both high intensity approaches were obviously superior to regular care. Okay, on the negative symptoms. However, on the negative symptoms, we did not. Now, this trial is being repeated by Kathy Stinney and Winston Biblow as we speak in 150 patients in New Zealand going earlier. But at least in this study, there was spontaneous recovery of the positive symptoms, just like there were spontaneous recovery of the negative, but we couldn't beat the spontaneous recovery, whereas we could for the negative symptoms. Okay, so interesting. And in fact, Gert Quackel, in a study doing constraint-induced movement therapy acutely, also found this dissociation. So I suspect that we might be able to go much earlier and even higher dose, or we're going to need, for the positive symptoms as a movement disorder, our DBS moment to combine with a behavioral platform. That's my suspicion. I will stop there, just we can take some questions. These are all the people involved. This is, of course, as you can imagine, very difficult work to do, to design the interventions, to get patients that early, to do all that kind of psychophysics. So it's very much a team effort. And I'll stop there. Thanks very much.
Thank you, John. So anybody with questions or want to make a comment, just
should I stop sharing? Yeah.
well,
John, you can share maybe while I'll start first. So John,
well,
great. Yeah.
So did you say yes, stop sharing or not?
no, it's a nice slide. You can leave it up.
Okay, all right.
Well, John, leave it here in case more revisit some of the slides. Well, great work and smart too. I think it's very difficult to design a study in the acute phase. There's a lot of logistic issues. But I think you had a very small sample size. I think it might be too early to control. You can improve negative symptom, feel positive symptom. I would wait a little bigger trial. I haven't read your paper on the NNR yet. What are the baseline kind of figure about scores? Can you kind of elaborate a little more about the study?
They had to be anywhere between 6 and 40. So they had to be severe to moderate.
So 640, that's quite a bit.
6 to 40, yeah.
Yeah.
And interestingly, it's interesting that that the group, but it's too small an N, so this is just me speaking, is that the people who really benefit from a really high intensity diet, well, there's 2 points. First of all, there's no question the result is real, okay? I mean, others have shown it too. I mean, let's be very clear. More is better, right? What we give patients currently is hopelessly inadequate, right, for impairment, okay? So that's one thing, right? What's interesting about this study is it basically showed 2 things, that just like Nick Ward and Janice Daly have shown, that if you give a lot of extra regular therapy, like 5 to 6 hours a day, like Nick does and Janice Daly did in chronic stroke, you can see effects on ARAT and fibromyalgia. What we did here was simply say giving a lot more regular therapy, and it was a lot more, right? The average amount of time spent on the upper limb in a regular upper limb therapy session, time on task, is 11 minutes, right? Catherine Lang has shown that.
Yeah.
So we did 2 hours time on task. Time on task, so just so you know, that meant the therapist had to spend about 4 hours with the patient. Okay. Now, what's exciting about the result is that a dolphin with no hand component is the first time that a game has come along, unlike robots, that actually is better than regular care, regular amount of care, and does as well as having a therapist have to spend a lot of time with the patient. And the trial in New Zealand right now, which is much bigger, you're absolutely right, you need a bigger N, is where you can actually have 1 therapist and 2 patients. Okay, now with respect to the negative symptoms, I think you're right. It could be a false negative result. It's interesting that Gert in his explicit study also found it. I'm hoping it's a false negative. I'm hoping that if you go really early, we're starting within the first week after stroke in New Zealand, that you can actually have an effect on that too. But what I will say is that we have to accept that hemiparesis has components, and we can't believe that the same treatment will be equally efficacious on those components.
All right, John, from the chat, any comments on the Raphael device, the smart glove?
Yeah, I think, to be honest, I really don't think very highly of it. I do think that we have to have an equivalent approach for the hand, but it can't be actuated. In other words, anything that actuates and assists, I think, is the wrong direction to go in. Okay. So you need to have something different, and actually we have something we're building for the hand, which I won't talk about today, but I think what that device points out is that we're really in a dark place when it comes to a way to do something for hand dexterity at the moment.
I like the next question. What about the age of the patient on all this?
Yeah, well, I mean, these patients were in their 60s and they were age matched.
No, but I mean more so the effective age on recovery.
Yeah,
I mean, we all think that an older person has much more trouble than a younger person. Is that what you find?
Well, we haven't done a direct comparison, right? I mean, if you look at the literature on this, right, whether it's stroke or TBI, there is a sense that, you know, the amount of behavioral delta that you'll get for a particular number of training sessions is greater when you're young than when you're older. It's difficult though, because sometimes the deficit to start with is worse for a given lesion size in a young person versus an older person. So it can be sometimes difficult whether it's the initial impairment for a given lesion that's the problem, or your actual responsiveness after you start. Now, it looks like when you look at the literature that both are true, but any sort of pessimism about the sort of older patients not responding is completely wrong. Right, you can get very nice recovery from both spontaneous and training induced in older people. Okay, but there is probably a difference, right? We'd have to do a pediatric study to show that you can get even more dramatic improvements.
So, Len White, you have a question for John?
Yes, thank you, John, for a great talk and a great book, which I had the privilege of reading last year.
Oh, wow.
If you have thoughts about the neuroanatomical locus of restitution with respect to improvement from the negative effects in your dolphin trial.
Yeah, so if you look, and in the book, you know, I went through studies by Bill Buford, and then by Warren Darling and others. What it looks like is two things. You're up regulating the strength of connections down into the spinal cord from premotor regions on the ipsilesional side. So it's been shown for dorsal premotor cortex and for the supplementary motor area in the monkey. So Warren Darling, for example, showed that there are connections down into the ventral horn from the supplementary motor area, and those connections are strengthened. It's very interesting that, you know, with Rich and Steve, we actually looked at the equivalent of the supplementary motor area in the mouse, and that was upregulated. We didn't look at connections. And then there are also evidence for strengthening of connections in the brainstem, for example, in the reticular formation. So the locus for the improvement of the negative symptoms seems to be upregulating connections from other cortical areas and the brainstem down to the spinal cord. That seems to be what the locus is.
And my follow-up would be, do you think there's also a neuroanatomical difference that might relate to the positive symptoms, and at least to date, the lack of obvious benefit over the control group that you showed in the study?
Yeah, I mean, it's very interesting that in the monkey model, it looks as though you have to make a slightly anterior lesion between the dorsal premotor cortex and the primary motor cortex in the monkey to begin to elicit positive symptoms. And then if you look at the Denny Brown book, he was getting them when he was looking at medial premotor areas as well. So it could well be, as you know, the cortico-reticular projections come from both hemispheres. So they're much less focused in the cortical spinal tract. So there has to be some effect of a suppressor region in the premotor and motor cortex that is lesioned, and that suppressor region, which is what it was called going back to the 1940s and 50s, allows the release of other cortical areas' effects on the reticular formation. So it's a complex answer, but I think what we're seeing is a failure of output from the dexterity regions and a loss of a suppressor region that allows release of other cortical reticular projections. And it's when you lesion the suppressor region, there may be more than one, that you get the positive symptoms. But we're just investigating that now.
All right, Dana Lott.
Oh, I thought I could just type it and I could get away with that, but. Well, first, before I ask my questions really fast, I just wanted to say that as a PT, I really did appreciate this talk, especially talking about Twitchell's findings that, treating a resting abnormality doesn't necessarily change the movement. And that certainly doesn't change what we know as therapists, that the fact that someone has, quote unquote, tone doesn't really tell us anything about their capabilities of movement. And I think probably one of my most favorite quotes about, these abnormal synergies was Gordon in, I think it was the late 80s, talking about, when someone has a lesion, it's not just the result of the loss of tissue, but then it's also the remaining attempt of the body to essentially compensate for the loss of the neural tissue. So someone's capabilities, when you go into a room and they quote unquote have a synergy pattern, doesn't tell us anything different about their movement capabilities, which it's nice to have someone kind of acknowledge that. But my two questions were, the reorganization theory being a myth is super fascinating.
Yes.
So what does that do to the work of Nudo and all
Yeah,
the findings?
I get this question a lot. So, the Nudo results, so those of you who may not know, Randy Nudo did some seminal, beautiful studies in the monkey, in the squirrel monkey, actually. He studied the squirrel monkey because they have a flat convexity, so it's much easier to get to cortical areas and do intracortical microstimulation. Did a series of studies where he made a small lesion in the hand area of the squirrel monkey. So there was a lot of hand area remaining intact, by the way, and showed with training that you could get restitution. Very similar result in the squirrel monkey to the one that I showed with Steve and Rich and the mouse. But it's extremely important to understand that that was a subtotal region of the hand area with a lot of residual hand architecture. 1. 2, map changes, in other words, showing what's called expansion of an area from which you can elicit hand movements from which you could not before when you do ICMS. That's completely explained by the fact that the gain has gone up on regions that were already dedicated to the hand, and now it's just easier to elicit a response from them. There wasn't a change in identity qualitatively of a neuron's tuning. Okay, and I've written an entire chapter with Tamar Makin in London about this, and we're writing a new one. But take it from me that the notion that you qualitatively change the tuning of a neuron or an area, so it now does something different to what it was dedicated to do at birth, is simply not true. What you do is you unmask latent neurons in areas that were already dedicated to that particular type of behavior. Do you see what I'm saying? But reorganization has that qualitative feel to it, that somehow the occipital cortex used to be for eyes and now it's for finger touch, things like that. All sort of magical thinking about switches of identity. And I'm saying that just doesn't happen.
John, do you want to make a comment on Prozac, antidepressants as a way to improve rehabilitation?
Yeah, I think it's an extremely important question. In other words, there have been a slew of trials since the original positive trial suggesting that there's no point giving SSRIs. Now, when we did a study, again with Rich and Steve, where we gave mice fluoxetine either late or early, the interesting result was if you gave the fluoxetine early, it allowed you to delay the training in the mouse and you could still get restitution. So in other words, our conclusion was that the fluoxetine could keep the window open, but it couldn't open it on its own. Nor could it have an effect unless it was combined with training. Now, the problem with the trials that have come since then is that they didn't do any training at sufficient intensity and dosage, A, and they came up with the most ludicrous outcome measures. They didn't look at impairment measures. So in other words, it's a beautiful question because the trials that have been negative are exactly what you will happen if you don't have a sufficiently well-focused behavioral intervention and you don't have a properly granular outcome measure. In other words, you're basically flying blind and then you publish the study and people think it's an important result. I mean, those kinds of trials are actually worse than negative and positive results. They tell us nothing, right? I hate the kind of trials which actually end up leaving you as ignorant before you read them as afterwards. So it's an open question right now, unfortunately, whether SSRIs should be used to maintain a window, encourage recovery, because we just have the one trial, now we have these, and I'm very skeptical that we'll ever see another trial.
Okay. John, here's a good question, again from Dana.
No, I think Dan already asked it.
No, but the second one, there's a lot of virtual reality already in stroke rehab. How's the Dolphin different?
Yeah, that's a great question. First of all, there is a lot of virtual reality and it doesn't work, okay? And patients who of 60 and up at the moment don't really like virtual reality, right? They have to have goggles on in the hospital. They trip over things. What we're doing is immersive. It's a room with a giant screen. Penumbra have a device which that they're using, and I'd like to see if they have an effect on impairment and dose. Also, we use animation of a very particular kind. It's a soft body dynamic physics engine whose behavior is emergent as you move. I'm against avatars or real life. I want it to be non-task based, and I want it to be emergent, and I want it to be enriching. Being in a Jetsons-like living room in VR, you might as well just be in the real living room. So I actually, and I talk about this a lot in another paper that I wrote, that I don't want avatars, I don't want human bodies, I don't want functional tasks. Okay, I want you to be in a different creature's body. And I can talk more about why that is. So there are games and then there are games. And to lump them all together is, in my view, as wrong as saying, well, why do we need to have a statin? They've already taken an antihypertensive, right? I think the games are as different as those two drugs are for stroke patients.
And go ahead, Wayne.
Hey, John. I just quickly look at your paper. I'm just kind of bothered by the fact that, you put a lot of effort to study proportional recovery, but you actually include a very wide range of the patient within 6 weeks, 6 to 40. And you clearly know some of the patients can afford a proportional recovery, some of the patients don't. I just don't know how you set up this, inclusion criteria, which you might be actually,
Yes, you're absolutely right. I mean, you're absolutely right.
I'm really bothered by the fact.
Well, actually, but I agree with you that by doing that, we could have included some non-recoverers, which would hurt us, actually. So in other words, you're absolutely right.
No. You actually, those are non-recovering, but you might be actually using in which, the Dolphin might be changes, but you include those proportional recovery, you clearly know they're going to get there. It doesn't matter what you do.
No. The whole point here is that you need to beat proportional recovery. That was true of the control group, right? The 200 patients in the regular group could have proportionally recovered too. And they never did as well as the two intensity groups. So there's no way that could be true, because that would be true of regular care as well. Okay, so in other words, the idea that you can beat, I mean, you're absolutely right. The whole point of this study was to see whether you could do better than spontaneous recovery. And we did do better because the two intense groups were twice as good as now they weren't as good as the Fugl-Meyer, right, which is what proportional recovery is about. Okay, so it may well be that we can't beat spontaneous recovery of positive symptoms. We certainly didn't in that trial. Okay, now in the trial that Kathy and Winston are doing, they are removing any MEP negatives from the study. So anyone who's MEP negative is not going to be included in the trial. So they're going to remove non-recoverers from the trial. They've started it, by the way, and go forward that way. So in other words,
I think that's a good start, but probably also you can do stratification to see if they behave differently. But anyway, I'll read a little more.
You're right. You're absolutely right.
Also,
yeah, but you're right that we'll have a much bigger N to be able to actually do that. Yeah. Right. But we'll start by absolutely removing the non-recoverers. Yeah.
So the other question I have is, it's good you talk about a positive symptom, which I think we actually neglected some of the positive symptom about spasticity. If you look at really the, Brunstrom stage of recovery, really kind of describe the ideal subset of stroke patient, how they actually recover. In the beginning from the, complete fracture, hemiplegia, and then a tone started, and then you have a synergistic movement, then tone further started, and then.
Yeah, I mean, all Brunstrom did is copy Twitchell. There's no difference, right? The Brunstrom stages are just a slightly reconfigured stages of Twitchell. What's nice about Agnes Brunstrom's book, when she was at Columbia, written in the 70s, is she actually suggested approaches to try and deal with the negative and positive symptoms.
I'm not saying they're different. What I think is they really describe a subset of stroke patients. They actually are getting better. The problem is a lot of patients doesn't follow the whole spectrum of a stage. A lot of them are just stuck in a,
Yeah, exactly right. I mean, that's the whole point.
Yeah, so I think the point is also is, if you look at it, we all talk about the sensitivity period in human stroke, which you look at it, it seemed to me is almost coincident with the intrusion of the positive side, because that's kind of, 6 weeks, then that's where the really spasticity become big issues.
Yeah, be careful of conflating spasticity and synergies. They're completely different.
I'm not a mixed of the two, but those two all interact with each other.
Actually, they don't, but they have similar time courses, but they have different pathologies, different bases. But you're right. I mean, and it leads to a paradox, which is if the Twitchell sequence is a kind of recovery from plegia, in other words, it's better to have a flexor synergy than to be plegic. How do you then upregulate the reticulospinal tract and then downregulate it again if you are lucky enough to get through the Twitchell stages? So in other words, so we don't know. And it's a great question. And it's something that we're worrying about a lot. We have a paper coming out with John Rothwell on this issue soon, I hope. But it's a very, very important issue. I mean, for everyone who's young in the audience, well done physiological behavioral studies of the natural history of progression of the positive and negative symptoms over the first 3 months after stroke is sorely needed. We've done it once, but there can be done a lot better. But we've got to tell the NIH, we've got to tell other grant agencies, you have to do high granularity behavioral and physiological studies of the phenotype so that we can actually get it to the bottom of the kind of questions that Wayne is asking.
Yeah.
We'll, anyone who needs to go can go, but we got John. Something about Twitchell, John. First of all, he was a pediatrician. And the second thing is he never made it past associate professor.
Mm-hmm.
Which just shows you.
It doesn't matter.
I'm just saying what it was like in the old days. Jody Feld, question.
Hi, yes, thank you very much. Always interesting to hear you talk. I'm a physical therapist as well with Dana, and we certainly teach our students and clinicians the importance of using task-specific training and saliency. And so are we wrong in doing that? And the fact that you wanted, and you mentioned not wanting a functional task with the dolphin program.
Yes,
I'm a little just curious to hear your thoughts.
Yeah, it's a really great question. Okay. And I think it's a deep one. And I want to make very clear on this because I don't want it to be some kind of, war, unnecessary sort of. So let me just go into that. And I'm going to give you an analogy. In the current AI, world of AI, there is this battle between DeepMind, OpenAI, and other such places that are using what are called benchmarks. So they go, look, can we beat a human at Go, chess, Atari games, etc. Okay. So what you basically do is you train the networks on a particular task. What they can't do, they're hopeless at the moment, is general common sense. In other words, flexible, abstract reasoning. Okay. In other words, we can do it across tasks, right? Rather than being trained up on one. Now, what we're beginning to see in that world is you have to distinguish between capacities and tasks, right? And what you want to do is you want to train capacities like dexterity and strength, because if you train capacities, you can use them in any task. So for example, a little child babbles with their arm all over the place, and they just get good at motor commands because they tessellate the motor command space, right? They're not doing any particular task. They're just doing statistical learning, all right? When you spontaneously recover, when a stroke patient spontaneously recovers, they don't spontaneously recover task by task. Oh, I've spontaneously recovered the ability to use a fork, but I haven't yet spontaneously recovered the ability to use a knife. Doesn't happen. What you spontaneously recover are your capacities.
Understood.
And what I'm saying is you have to come up with a high intensity, high dose intervention that covers the multidimensional capacity space. Then, once you've learned capacities, I have absolute belief that you should then show them off in task space with the therapist. But tasks cannot be the way to train capacities, right? So you have to have a capacity approach, and then you have to have a task approach, and they complement each other. Do you see? And the mistake is to think that you can do capacities with tasks or tasks with capacities.
Understood.
But unfortunately, that rehabilitation as a field totally forgot about capacities, right? And it just said, well, to the degree that we'll train the capacity, we'll do it within the context of particular tasks. And what I'm saying is you simply can never get the number of trials needed to get the capacities trained up that way. Does that make sense?
Yes, it's a different way of, I think not a different, it's a different, I guess it's a different way of thinking about it. So an important one though. Thank you for sharing.
You don't have to be convinced by John right away.
No, you don't. He's an acquired taste, John. So we have another Jody question, Jody Hawes.
Yeah, I'm just curious about this idea that using the animal is better than a human. And I'm just wondering how that changes your neuroanatomy, or, you know, what else does that tap into that is beneficial? Yes,
such a great question. So in other words, I think there are a number of reasons, and you know, and these are ultimately empirical. I think you want to have somebody have two things happen simultaneously. You want to give them the sense that in this new environment, they're actually skilled. You don't want them to think or be reminded of what they can't do, okay? So when you're the dolphin swimming, you can get better over time, but you're immediately a dexterous, beautiful animal, even with your stroke. So it gives a very positive feeling that you have motor control. It also encourages exploration all over your motor command space, because there isn't a simple mapping between the dolphin and your arm. Whereas if you were looking at an avatar of your arm, you wouldn't explore very much because you'd simply keep trying to do what worked before you had the stroke. Okay, so in other words, you'd be locked into your prior. So I want to get you away from priors. I want you to feel good. And I want you to encourage to just explore all over the place. I want you to do what children do. I want you to babble. And adults are very unlikely with avatars to babble. All they'll see is a recapitulation of their deficit. All right. And they will try and do task-based movement rather than capacity movement. So I want to uncouple capacities from tasks and priors. That's why we do it.
So John, Jody Feld asked another question, which I was thinking of too, which is the idea of generalizability. So in other words, if you just rehab like crazy on pointing to a target, you know, the multiple circle challenge you have, do they get better at grasping? Or is it just they're better at the one specific?
Yeah,
task?
so that's okay. So that's another great question. First of all, the circles is just an assessment task. That's not a training task, right? In other words, that is simply to assess arm dexterity. It's an assay. It's not even a task. Okay. So we would never train. All it is like a behavioral blood test. Instead of getting your potassium and your sodium, you're just getting the level of motor control of your arm. Okay, so let's just get that out of the way.
Yeah, so I agree. And so my question was specifically in spinal cord injury research. I understand and could be understanding it wrong, but I understand that there have been studies that to show that if we train, you know, standing alone, we don't see improvements in gait. If we train gait alone, we may not see, you know, changes in static stance. And
yeah, so that's absolutely right. So let's get to this, okay? And this is very important, all right? Because people conflate plasticity, motor learning, and training. Okay. So spontaneous recovery, training of capacities are a way of getting more generalization. Also, making people babble in the statistical cloud of everyday life. So in other words, I wanted generalization by one, training capacities rather than on tasks, going early to take advantage of spontaneous recovery, right? And babbling all over the place, all there to generalize. What you're talking about is what's called in the motor learning literature, the curse of task specificity. Okay, and you're absolutely right that the generalization function for tasks on motor learning principles is narrow for most tasks. Training of capacities on top of spontaneous recovery is not motor learning. It is completely wrong to call training of the nervous system motor learning. All right, it happens all the time. I despair of it. And a way to intuit that is you wouldn't say when you train your muscles, which you do, that your muscles have learned anything, right? Of course they haven't, right? So this is a conversation and a talk for another time to distinguish between the effects of training on the nervous system to enhance capacities versus practicing through motor learning to improve on particular tasks. Those are very different conceptual universes. And unfortunately—
Was there an answer in there, John? Did you say whether the dolphin generalizes?
Well, yes. I mean, we did Fugelmeyer, ARAT, and kinematics, all our outcome measures. None of our outcome measures within the dolphin game.
Okay.
So, right, in other words, there wasn't a single dolphin outcome measure. It was the ARAT, which is a grasp task. It was the Fugelmeyer, and it was kinematics of the hand and arm. We used all four. They all improved. Okay, so we had total generalization, actually. Right now, do we want it to be better? But it generalized the way spontaneous recovery generalizes. And I think that's because we were training capacities. We don't consider the dolphin a task in and of itself.
Do you think language would improve too with the dolphin?
That's a very interesting question. In fact, somebody is currently writing some sort of grant to do that with us. I mean, it's a very interesting question. I mean, the therapists all tell me who do it that it's very cognitive, the game, which it is. And, you know, I forgot to mention that we didn't train the hand in the dolphin task, and we did just as well at the hand as the therapist who did 2 hours. So it's very puzzling to me that we did no hand training and we did as well as a therapist who were allowed to do hand and arm. So that's fascinating to me. But yes, that's a great question. That's a nice lateral move question I like. And I don't know the answer to that, obviously, but there are some rumblings that might be an interesting direction to go in.
All right, that was a great question and answer session. John kind of inspires that, and he brings the best out in other people. Just because he's so dogmatic, you want to rise to the occasion.
Look, I'm not dogmatic. I'm just right. No, but the questions were great. And I think we're only going to be able to, in all seriousness, we're going to have to really think through the components of hemiparesis, distinguish between task and capacity-based training, make a distinction between motor learning and repair, and really get these distinctions down so that we can design treatments together that are more effective. I mean, but I do think that we're going to have to go through the splitting stage before we do premature lumping. Pragmatic lumped trials, in my view, have done nothing but harm.
All right, everybody. John, always a pleasure.
Thank you for inviting me.
You know, one of the reasons we scheduled you now is we assumed that the plague would be over by now and you could actually come down. So maybe in a year or so, John.
Okay, I would love that.
All right, everyone. Have a great day. Thank you, John, as always.
Bye. Take care.